addressing. Awesome. Thank you so much, Matt. So I'm going to go ahead and just start dropping some links in the chat for people to look at. Those will be the Word documents for the Good Samaritan Law. I'm pulling them up as we speak. I'm going to get a link. Got it. Okay, thank you. Thank you. That's so nice of you. Anyone with the link, copy a link, and we're back. Okay. Okay, so those are the two Word documents for the Good Samaritan Law that Anna has been so kind to make for us. And I will go ahead and pull up the presentation, and then Anna, you can go ahead and get started.
Okay, thank you.
Okay, it's going to be this. Okay. I'm sorry it's taking a little minute. I will say, don't ever have clammy fingers and use a trackpad. It's not the moves. Okay, so share this, and there we go. All right.
Thank you. Okay, so my name's Anna Stein, and I'm really honored to be here today with you guys. I work at the North Carolina Division of Public Health. I work closely with the Injury and Violence Prevention Branch on their overdose prevention team. And I've been doing this work with them for about the past 7 years now, and have really delved into harm reduction policy and have been able to work on some harm reduction legislation in the last few years. So I wanted to highlight two of our really important harm reduction laws, the Good Samaritan Law and our Syringe Services Program law. But I want to highlight what we want to change about those laws. So I'm happy we have them, but we need some improvements. So wanted to give some people some thoughts for future advocacy. So next slide, please. So I wanted to go over just real quickly what is in our current Good Samaritan law. What it does is that it protects people who call for help for someone who's overdosed. It only gives them immunity against prosecution. It does not protect them from being arrested or charged with a crime. And it only covers prosecutions for paraphernalia and for certain types of drug possession. So only misdemeanor possession. And then if it's felony possession, just for heroin for less than a gram and for cocaine of less than a gram. So methamphetamine, not protected. Fentanyl, not protected. Anything outside of this the categories listed here, not protected. Another thing, the person must have a reasonable belief that they're the first one calling for help. They have to give their name to 911 or to law enforcement. The law does protect both the person calling for help and the person who has overdosed. Next slide. So what do we need to change? We really need to change and add protection for arrest and charge instead of just prosecution. The majority of states, almost every state has a Good Samaritan law, and the majority of states have protection for arrest. So this is not a crazy idea at all. And this actually, I was doing some advocacy work on behalf of these changes earlier in 2021 and talking with different like law enforcement, district attorneys, people that might be opposed to changes in the Good Samaritan law. And this actually was not a controversial change. So that's exciting. And I would say that's the number one change we need to make, because when people call for help, they don't want to have to go to jail, and deal with, withdrawal in jail. So just arresting alone, we need to get protection for that. So another protection that we need to add is that we need to protect other people who are at the scene besides just the person calling, because that could be a real hindrance if other people who are at the scene are, are afraid that they might get arrested. That's not good. We also need to clarify that a person can call for help on their own behalf. It's possible that you could read our current statute to say that people are protected. But most states make it very clear that a person can call for help on their own behalf. And I mean, obviously someone who's overdosed isn't calling for help, but there could be people who are sick, they don't feel good, and they want to get help, and they should be able to call and get help and not worry about getting arrested. We should give immunity for all possession charges. We shouldn't limit it to particular drug types, and we shouldn't set limits on weight. One of the major issues with our Good Samaritan law is that it's so complicated that we can't advertise it. I mean, you have so many asterisks of, the type of protection, like, well, but it's only for this drug and this weight. And that's not helpful. So we just need to be able to say, you're going to get protection for drug possession, period. And most states do just protect for drug possession, period. So, and also paraphernalia. So this is also not, an outlandish change to ask for. So we had actually had a bill introduced in this session, House Bill 852. And then it accomplished these goals that I'm talking about. And I actually, Deshay had put the links to, I had two documents. One was a one-pager on the bill that we had created that highlighted what changes were in the bill and why we needed them. And then also a briefing document that we had given to legislators with just a little more information on why these changes were needed. And I've given them in Word document form in case people want to steal from those documents in the future. But we had some really good advocacy from the North Carolina AIDS Action Network, from their lobbyists, from the Harm Reduction Coalition. DHHS, officially supported this change. But at the end of the day, we couldn't get traction to get out of committee. And I just say, kind of looking back, it took us so long to kind of try to get buy-in from law enforcement and the DAs that it took a while just to get the language coalesced. And then it was kind of too late to then start working the legislators and introducing them to the language. So this type of advocacy is very time consuming. And I will say just another thing about advocacy and passing laws is that legislators don't like messy things. They don't want you to come to them and say, well, there's a lot of disagreement about this, but we want you to do this. They don't want to hear that. They want to hear that everybody's kind of coalesced on this language. And then they want that language that you've already kind of gotten agreement on. And so that's what we were trying to do is talk to the folks that might be opposed to our changes in advance before going to the legislators. So just want to say that's one of the unpleasant things about advocacy, but one of the necessary things to do. I wanted to point out that many advocates would love to see death by distribution added as in the immunity for under Good Samaritan. In fact, it makes a lot of sense because obviously, when you're thinking about what's going to be making someone afraid to call for help, if they're afraid of a possession charge, of course they're afraid of a manslaughter charge. So, obviously on the principle of the matter, it makes a lot of sense. as a practical matter, the only state that gives protection for death by distribution is Vermont. It's shocking to me that Vermont has death by distribution, but they do. But in Vermont, they provide protection in their Good Samaritan law for literally any controlled substance offense. So just across the board, they don't even list them out. It's just like anything under that chapter, and death by distribution is in that chapter on controlled substances. So just politically, it's a tough sell, I'll say, to add death by distribution, given that it's not been done by other states that might be considered more liberal than North Carolina. So next slide. So I also wanted to talk about our syringe. I say syringe exchange here just because it's that's the way it's labeled in the statute. It says syringe exchange, but we typically use the term syringe services programs. So a change that we would like to see in our syringe services law is to broaden it beyond just injection supplies. So right now, our law provides immunity for the distribution of needles, hypodermic syringes, or other injection supplies, or residual amounts of controlled substances contained in injection supplies. Next slide, please. But what would be good is if we could change that term injection supplies to something broader, like a drug use supplies. And then our syringe service programs could distribute any type of drug supply that someone might want. And then what that would do is it would allow our syringe service programs, which we probably need to start changing that term syringe service program at that point, would allow them to make connections with people who use non-injected drugs. So, that's really important when you see the rise in cocaine use, methamphetamine use, other types of drugs that might be smoked or snorted, and also would allow us to make better inroads among communities of color who might be using other drugs besides injected drugs. So, looking at our syringe services programs report for this past year, 2021, the breakdown of participants that were reached, 9% were unknown in terms of race, but of the remaining amount, 77% were white and 8% were African American. So, you can see we need improvements on reaching our Black community. When you look at who's overdosed, 87% of the people that overdosed in North Carolina during that, I don't know what time frame, that I should know that, were white, and then 13.5% were Black. So when you look, if you're just thinking about overdoses and you think we reached, 8% of syringe service programs were Black, but then 13.5% of the folks that overdosed in North Carolina were Black, there's a mismatch there, obviously. But even just taking aside overdose as an outcome and just thinking of like people who are using drugs that need health services, obviously we need to do a better job of reaching Black North Carolinians through our syringe service programs. And, broadening our focus beyond just injected drugs would allow us to think of syringe service programs as drug user health hubs, which is something that all of us want to move to. So, this broader focus on healthcare for people who use drugs. And so it shouldn't matter whether they're injecting drugs or using drugs in some other way. So this is a change we would love to see. So far, I have heard resistance from law enforcement on this idea, and I could talk more about that later. But next slide for another way to tackle this. So I don't know if this is a better way to do it, but I just wanted to point it out. There's an alternative way to tackle this problem. That would be to make changes in our paraphernalia law instead of in the syringe service program law. So some states don't criminalize paraphernalia at all. So if we didn't criminalize paraphernalia, well, we could hand out whatever supplies we wanted and they wouldn't be criminalized. That's probably a tall order politically in North Carolina. But there would be some more narrow ways to do this. You could try to decriminalize the possession of a certain type of paraphernalia, which is just paraphernalia. And it says designed to introduce drugs into the body. That's like what it says in the statute, but paraphernalia that people use to actually take the drug. And so we have examples of this. The District of Columbia in December 2020, so less than a year ago, decriminalized the possession of drug paraphernalia for personal use. So they weren't trying to protect people who are selling drugs, like scales and baggies or whatever. But if you have that, the drugs on you and whatever paraphernalia you have, you're going to use it to use the drug, that would be decriminalized in District of Columbia. And North Carolina's paraphernalia law, we currently, in 2019, decriminalized one type of paraphernalia, that's testing equipment for personal use, and allow distribution of it by community groups. So this was our fentanyl test strip law is what this was meant to cover. But, it's a nice precedent of carving out a type of paraphernalia. So potentially we could, put in a provision or paraphernalia law to decriminalize paraphernalia designed to introduce drugs into the body, and allow its distribution by community groups. And that would also be another way of getting the change that we wanted. So that's all I have for now, but happy to take questions at the end.
Awesome. Thank you so much, Anna. I already have questions and things I want to talk about, but I'll save it to the end because I know I'm going to have even more questions. Y'all know I like to take notes. And so next we're joined by Louise Vincent from the Survivors Union. So excited that Louise is here to join us and talk about some of the community level engagement that they've been doing around some of the harm reduction policies. And it's all you, Louise.
Great. Thank you. I don't have any slides today, so you can just leave the screen the way it is. I'm going to hide my phone because I can't figure out how to turn the ringer off. Thank you, Anna. I'm always really really glad to hear what you have to say, and really amazed by your commitment to this. There's so much involved, and there's so many moving parts, and I think, from all sides, we all want what we want. And it is really difficult to understand if you're not in this sort of world, all that has to be done to get everybody on board. And I think if anybody has explained in a way that I have at least some ability to understand just how hard it is to get every single person on board, and all of the discussions and all of the sort of come this way, and just how we have to be careful with language, and and the different things that we say. It's Anna. And so I'm really glad we have her fighting with us and working on these pieces. The first piece about the Good Samaritan law, there's all I really know to say about that is the heart and soul of that law. And that piece of legislation is around us concentrating on the person who's dying, right? That's what we want to be doing. We want to be, maybe they had other things on their mind, but at least when I think about the Good Samaritan law and why we would have a Good Samaritan law, the essence of it is that I don't want people thinking about the dope they've got in their cabinet while they're trying to bring back somebody they care about to life, right? We want them focused on mouth-to-mouth resuscitation. We want them focused on doing the work of bringing someone back so that they can be okay. And when you have those things on your mind, and I'm just going to be honest with you, I've been in these situations. When you have these things on your mind, they are competing thoughts, right? You can't help it. Going to jail, I am afraid of nothing more than I'm afraid of the police. And that is the general sort of conversation that I hear from people that use drugs. There's nothing more frightening to me. There's nobody, no monster, no, nothing. The worst things that have been done in my life and to me have been done by the police, and my feeling powerless. And so even calling the police is really difficult, or calling someone where I know the police are going to show up. And so the amount of time that gets passed when you're thinking about these things, all of those things, we've got to remember that people have been traumatized. People have been traumatized by the police. We know this. We know that police, I'm not here to bash the police. I'm here to say that we know that police misbehavior and the kinds of things they do, exists. And so we have to take that into consideration. People have had whatever experiences they've had with the police. And we know that, and we know that people have trouble calling them when they're in trouble. People that live in underground economies, people that use drugs, people that are in situations where they're running into the police a lot, and they have complicated relationships. So we know that these phone calls can be hard to make. So we have to do everything, in my opinion, as a community, to make that phone call happen. Or if we can't do that, if we can't find a way, then we've got to find some sort of community group that shows up instead. Because what's happening right now is and I don't know what the statistics are. I've been trying to find out what that looks like, and I don't know how hard it's going to be. I hope we're able to put some numbers to some of this. I'm trying to find it. I don't think we have as many people calling 911 because of death by distribution. It's great if I don't get charged with possession, but damn it, if murder is on the table, it's kind of, and I gotta say, I was out of town. I had somebody house sitting. I came home. I don't know if any of you remember Beck Brooks, and she didn't die of an overdose, but it's the only thing that I knew could be wrong with a person or how to fix. So I had naloxoned her. And so when the ambulance came and the police came and all of this, they very much were focused on what's going on. Is she using drugs? And it absolutely wasn't the case. But I did catch a glimpse of what it would look like to have the police asking you about what's happening and why are they using drugs and all of this, and and feeling targeted. I did catch a little glimpse of what that would feel like, and it was really awful. And I was watching someone I loved very much die, and the police were very much concerned about what kind of some other stuff, and I have never been I have always been really moved by these laws and really worried about them. But that was the first time I really got a sense of just how devastating, just how absolutely devastating, and just how complicated things can get really quickly. And so I think it's really important that we think about these things, that we find a way. That the law is absolutely too complicated and it doesn't make any sense. And you have weight amounts that don't make any sense. So if I can have a gram of this, but I can't have a gram of that, but a gram of pot is very different than a gram of fentanyl. So these things they don't even make sense, like if you understand drugs. So that's a bit problematic, just in terms of what does all of this mean? There's demonizing of compounds of drugs and crystal meth, which is always demonized. So what are you supposed to tell people? All right, well, make sure that this bag is less than a gram and you don't have any crystal meth. You get that? If the essence of the law or the legislation is that we can concentrate on the person who's in trouble, who's in a medical emergency and needs my focus, because mouth-to-mouth resuscitation and naloxone may seem like an easy lift, in a training, but I'm here to tell you, when it's the person you love in front of you dead on the floor, it is not easy, and you need every bit of your wit about you, and you need to be focused, and you need to be thinking about that and nothing else. And so I think we just have to remember that is what we're trying to do with a law like that. We're trying to save lives. We're not trying to do anything else. And so keeping that in mind, I am, and then, so I think there's a lot of arguments right there for making those changes. But, at the same time, while we have death by distribution, it makes it really complicated. So I think we have to really think and be strategic about what we can do, what we can't do. There's equity that I want to talk about, and that sort of sits with the next piece of this. We don't have an equitable situation going on here. We talk about syringe service programs. We give away syringes. But if we're thinking about this in terms, that's my ringer that I can't turn off. It's like a baby. It was cute the first 25 times. So if we think about like the way this works, you're gonna help somebody reduce disease by providing them with syringes, but we're not gonna help somebody reduce disease, or we're not gonna help anybody reduce their harm by giving them anything else, which is really strange. If people acquire hepatitis C in the first 2 years of injection, right, then we don't want to wait until they're injecting before we provide them with supplies. We want to be seeing people. What my vision, or what I would hope, and the people that I talk to, is that we have somewhere that from the very beginning, from the very start of being interested in substance use, or being interested in drugs, or having a relationship with drugs, that you have somewhere to go and talk about that relationship and sort of investigate that relationship and have some people that can be honest with you. And that's going to require that we do something besides have a syringe service program, right? Because there's a lot of people that think they don't qualify. I'm not near bad enough to go there. I'm not near, that's beyond what I've got. That's beyond my issue happening over there. And that is unfortunate, because we want people reducing harm by snorting, by smoking, and now we have COVID. So we really need to think about what it means to be sharing pipes and things like that. And so that's added to the harm there, but when I think about equity, and when I think about who we see, and I have not yet found a SSP in North Carolina that is seeing people of color in the kinds of ways that I believe they should. It is directly, I believe, related to the kinds of supplies we give out and the way we talk about opioids, and it being connected to the opioid epidemic. And that's just not okay. We need to be talking about other drugs. We need to be talking about whatever drugs are interesting, or on MTV, or on, whatever young people are talking about, whatever, lean and zine and bean, like all of that shit. We are in a synthetic drug crisis. So we have A1, A4, we have drugs with no names. We have drugs that we call other drugs. We have a situation happening. And if we are only focused on opioids, we're focused on a population that, yes, they inject drugs, but they're not having loads of sex. They're not having, we need to be thinking about injection drug use and crystal meth. We need to be thinking about all of these synthetic drugs where we've got sex, we've got, you've got multiple, you've got like all of these things going on. I am unclear on why we have it limited so tightly. Well, I'm not unclear. But I think we need to start talking about what that means, and be really honest about what that means, because we can say it's this or that, or it's, well, syringes are a vector for disease transmission or whatever. We are not seeing people of color when we're only seeing opioid users and providing syringes. There's an easy way to open this up so we're seeing more people. And that is to make this a drug user health hub, and to really, why would we just talk about one drug? I don't know any drug user that uses one drug. I'm just gonna be honest. I don't know any, I have drugs I like, I have drugs I don't like. I use some drugs I don't like when I don't have the drugs I like. And I have bunches of drugs that I use all at the same time. I can't imagine if I had to go to a center for every drug I used. I'd be at centers all week long. So we really need to think about the truth, about what's happening. And we know that with fentanyl and the analogs of fentanyl and the insanity around fentanyl and how strong it is, people are unable to stay awake without adding stimulants. So we know that we're seeing more stimulants. We know that we're seeing these other drugs. And if we're not addressing that, it will eventually cause more harm to we're eventually not going to be able to do any good with just the syringe service program. So I don't want to babble on and on. There's so many things that we can do. There's so many things we can do. And having people like Jen and Anna and people that have the ability to sort of unpack this, we are learning how to develop like at least teams of people that can help explain to folks what's going on. And the teams of people are, the people that use drugs, the people that study drugs, the people that legislate and attorney over drugs, all of make the legislation, all of these things are important. And so getting all of these people together and not forgetting that we have to have meaningful participation and meaningful inclusion of people that use drugs at the table while we do this, then we can make a difference, and we can change some of this, or we can continue in the path we're going. And we're sitting at about 100,000 people a year dying of overdose. So I guess we can just keep going up. That's the other alternative that I don't care to have any part of. I think we can do a lot better. And I think we are situated in North Carolina to do a lot better. We have everything that it takes in place. And now it's just a matter of political will and some leadership so that we can get the people that are already sitting in place ready to do this with the right tools to do it in a way that makes sense. So all the hard work has not gone to waste. We've worked hard over a lot of years to get things situated so harm reduction can come in and do some things. Now we just have to get it right and listen to the people that know. And so, yeah, I'm really glad to be here and really glad to be with some people that know how to get it right. Thanks.
Can't believe that was only 15 minutes, because I feel like I could use a whole another 15 minutes. I feel like 15 minutes is not enough for all of you all to present, because this could be a whole hour-and-a-half webinar for me, but that's just me personally. Thank you so much for that, Louise. From the personal experience to the work to the dedication, thank you, thank you, thank you. Thank you so much for reminding us that a lot of the work that we do comes from the heart. That's where it starts, and that's where it always comes back to. So thank you. And to wrap us up, we've got Jennifer Carroll. I'm so excited with these slides. I love some animations. I'm going to try to allow you to share your screen.
Yeah, let me do that. I'll go ahead. Ooh, it says it's disabled screen sharing.
Okay, I'm going to make you a co-host, and maybe that'll allow you to do it.
I'm going to ask in advance for your understanding about exactly how many tabs I have open in my browser. Thank you. All right. Go, little friend. Go.
That is always my problem, Jen. I've got so many, it should not, they should have it cut off.
Is that showing properly, or are you getting the presenter view? Looks good? Okay. Super. Thank you, Louise. You make me feel so seen. I love it. All right. So I'm going to be talking a little bit about some strategies for engagement to promote harm reduction through policy. I really want to thank Anna and Louise for, I think, speaking so cogently about some of the challenges that we face and the type of wisdom and resources that we need to really mobilize in order to get things done. I learn so much anytime either of these two women pop up on a Zoom call. I'm like, yes, it's going to be great. Grab my pen and paper. It's awesome. So I'm really, really grateful for the two of them. I was looking around this Zoom room earlier, and I think that I'm going to spend the next 10 minutes telling all of y'all some things that you already know, but we're going to have a good time doing it. So I owe an awful lot, in addition to Anna and Louise, to one Dr. Talid El-Sabawi, who I am very proud to call my work spouse, who is currently an assistant professor of law at Elon University School of Law. And she has recently turned me on to a way of thinking about policy change that has I'm like, the clouds have lifted from my brain, like the scales have fallen from my eyes. I'm an anthropologist by training. And so like the thing that I say more often than anything else is that we don't really move through the world as people based on like rationality or data. We move through the world based on stories. And that's why the vast majority of like the psychological work that we have to do, whether it's about trauma or, what we're going to do with our day or that relationship that ended badly is sort of re-narrativizing and reshaping our stories around the data that we have. So there is a book that Talib recommended to me a while back called The Policy Paradox by someone named Deborah Stone. And it really helped me take that awareness that I had as an anthropologist and connect it to how do we make policy change. And I threw this picture up because my second favorite thing to say, other than we act based on stories, is that like oftentimes we have this goal and that goal is really far away from where we are. And the path in between, like there be dragons. It's the spot on the medieval map where you're like, I don't know, let's just put some things with fangs and wings in the ocean and we'll just assume that there's something there and we'll map it when we get there later, right? And so one of the things that this book really and Talib really has driven home to me, which is nice, is that data can reduce uncertainty, but it can't reduce ambiguity, right? Data can tell us, for example, like how many people died of an overdose this year, how many community reversals happened. It can tell us how many unplanned pregnancies there are in Texas or how many individual humans are lined up at the border. It cannot tell us whether or not that's a good thing or a bad thing, right? It cannot work through those moralized narratives that we have about the data. And because of that, data can be read differently according to one's own morals, emotions, and values. And I think this is a really, really true thing. And if you want any other example about how different human beings read data differently, like show data on the outcomes of cancer treatment to an oncologist and to someone whose loved one just received a diagnosis, you're going to see very, very different understandings about how that data should be put into action, right? And again, people make decisions based on stories, not evidence or pure rationality, and that data is only one kind of story. So a lot of us here are focused on policy, focused on public health, and data is my story. Data is my love language. I think data is a lot of our stories, but that does kind of make us weirdos. That is our motivating story. Not everyone, and especially not everyone in the General Assembly, is motivated by that story over other types of stories. And so the example that I wanted to bring up to sort of indicate how important this is, how important it is to have a real, I think, broad spectrum of voices in order to tell stories and to tell different kinds of stories is really necessary for change. I wanted to talk about HB 918. So this is a policy that came up, oh Lord, it has been a long pandemic. Was this summer 2020, y'all? I want to say 19, but yeah, okay, it was summer 2020. And this was a bill that was capital N, capital G, not good. And what it was essentially, in very, very brief terms, it stood to enhance the civil penalties of substance use during pregnancy. Civil penalties being essentially accelerated or more likelihood of child removal, accelerated time to the termination of parental rights. It really greased the pathway to separating families because of evidence that substance use had happened, not the documentation of actual neglect, not the documentation that a child is actually at risk, just like a drug happened, a parent was near the drug, let's separate the families and accelerate the time to the termination of parental rights. And it was bad. So a coalition formed in opposition to HB 918. I'll end your suspense now. We actually were able to talk the governor into vetoing the law, which is really, really good. And from where I stood, I know there were a lot of folks that were involved, but I really felt brought into this, not like, this is not something that I created. It was something that I got kind of looped into, but it was a group of large not-for-profits, small not-for-profits, faith organizations, advocacy groups, user unions, harm reduction, reproductive justice groups, and more. And I think the thing that's really important is that coalition relied on previous organizing work and the networking between organizations. This was not organization that could have been done when the need arose, we had to have a band to get back together in order to be able to do this. And I think that's one of the biggest lessons that I've taken away from this is like you need to just have those regular check-ins. Like you need to hop on Zoom or like set a call and build those linkages. I'm really, really grateful for Roxanne Saucier at the Open Society Foundation, because she actually was like this next level Superman dot connector getting us all together. We couldn't have done it without her. And what that coalition allowed us to do, even though each of the individuals and organizations that was involved in that network was planning on doing campaigns of their own, like no one was planning on sitting on their hands during this, but we produced shared resources. So folks are able to put together language, blast our email listserv, share resources, share links, share statistics, share graphics, infographics, things like that. And it really harmonized our messaging, and it produced shared action plans and energized the opposition, because we all got to kind of get in a room and like huddle and get each other energized up and then go back out to do 10,000 exhausting mail merges to like every single legislative aid in Raleigh. And this coordination was especially important, not just because it fed us while we were spilling out all of this energy to try to oppose this bill. But there was something that happened during the 11th hour of this bill. The Democrats, seeing that it was very, very likely to pass, even though they opposed the bill, put together an amendment that was going to essentially excuse individuals from the worst consequences of this law if they were enrolled in treatment for substance use disorder. And I think that the people that we spoke to, I left our conversations with the impression that they too recognized that that was a pretty weak sauce when it came to improving the law, but they're like, if it's going to be law, can we, and it's going to have 100 fangs, can we remove even 2 of those fangs? That would be helpful, right? And so it was coming from a good place in an effort to make like a really, really terrible law just sort of terrible and create any opportunity for someone to escape those outcomes possibly. What we worried about though is that this amendment, if sponsored by Democrats, was going to weaken cover that was being given to the governor in order to veto that bill. We're like, we need y'all to be a unified force. We need every single Democrat opposing. We need every single Democrat clearly opposing, not only voting no, but like just being like not touching with the 10-foot pole. And so again, I was not there, but the understanding I got is that there was an amendment slipped under the office door of one of the Republican sponsors of the bill. And so they got the amendment through, removing 2 of the 100 teeth of this law, but allowed the Republican sponsors of the bill to actually take credit for that amendment. So they were able to get what they wanted and maintain a really clear opposition. And it was, I think, our coordinated messaging around that to all Democrats that really facilitated that happening. And so the reason why I think it's important to have these really broad coalitions is a few reasons. And this is where we get to stories. So one of the good things is that I was able to be involved really, because there is a role for advocates with initials for like the PhDs and the JDs and the MDs and whatnot after our name. On the right, and if anyone wants to see this, I'm happy to share it with you, but I write a lot of long letters with many citations at the end of them about like, this is bad, citation, this will hurt people, citation, this will reduce access to treatment, citation, citation. And so this on the right is an example of a letter that Dr. El Sabawi, that Dr. Bela Ostrach, put together, and we're just sending to every single Democrat that we could find. We did the same thing talking about the financial impacts of the law that we sent to Republicans. If you're interested, we actually converted most of those letters and that research that we did into a commentary that came out, or because journals are weird, it will come out in December in the International Journal of Drug Policy. It shouldn't be paywalled yet, but if it is, shoot me an email. I'm happy to share it with you. And so our ability to really just come from that place of socially endowed authority and be like, this is a fact and you're not able to bend it, and therefore you have to make your narrative fit the facts, like this will disproportionately hurt Black and brown people, this will reduce interest in seeking treatment, so on and so forth, was helpful. And the Democrats especially several of them were replying to our emails and being like, this is so interesting. Gee, I sure wish I had some data on what the outcomes were of young people separated and put into the foster care system before they were 5. Okay, great, have a good day. And we're like, fabulous, let's do that next. And so there was this constant back and forth with data. And especially on the floor of the Senate, when this bill was being debated, the Democrats were like, fact, citation, fact, citation, fact, citation. However, Republican senators were not doing that. When we were listening in to the session as it was being debated and eventually did pass the Senate, what stood out to me is that the vast majority of Republican senators and representatives in our General Assembly supported this bill. Those who did not, though, did not one single time appeal to data. They did not appeal to facts. They did not appeal to science. They said things like, what if this was your grandkid? Right. And they said, no one here can tell me that they have an adult child who has never been in the same room as marijuana. And like, what would happen to you? How would you like this to happen to your family if there was this one-off thing that happened a while ago? And they were telling this sort of moralized story about substance use versus substance use disorder, but it was really asking people to identify very closely. They were telling a different kind of story. And the ammunition that they got to, I think, not only tell those stories, but to organize their own emotional orientation and their own moral orientation to the problem came from folks who it's not a perfect term, but I've glossed them on this slide as folks who are unwilling experts because they themselves have lost children because of their substance use or have been threatened with child separation or have experienced that kind of discrimination. And I think what's really, really important to emphasize is that, like, all the initials in the world do not empower me as someone who does not have children to do that work, right? And me as someone who has not experienced that specific kind of state-sanctioned violence, I cannot do that work. We had to have people who had lived through this, experienced it, understood it, could speak personally about the terrible, terrible impacts that they had experienced in order to do that work. And in the end, we actually did pull some Republicans over to the no side, right? Which I think is an extraordinary accomplishment for this particular collaboration. So I know that I myself have been on a bunch of calls this week where, like, the Nothing About Us Without Us slide has been up and talking about involving people who use drugs and directly impacted people. And, like, yes, that's all true. I think what I really want to emphasize is that, like, this is not just about appropriateness, it's about necessity. And we cannot, however we want to define like the job that we need to do in order to move our policy over from moralistic, stigmatizing approaches to substance use over to actually supporting people and helping people and keep them safe cannot be accomplished if we continue to marginalize people who are directly impacted by these laws. So one of those calls that I've been on in the last week or so has been about the North Carolina opioid settlement. There was the OPDAC call last week, the statewide opioid call. And that was actually a deeply, deeply informative opportunity to learn about where we are with the memorandum of agreement for opioid settlement money, where it's going, how people are allowed to spend it. And I think a lot of us who especially have spent the last few years watching the Ridiculous Truth campaign videos on TV and being like, how are we going to waste this money? Just like we wasted big tobacco money. I can't wait to find out, right? Are kind of sitting on the edges of our seats, waiting to figure out or see, like, where opportunities are for this to break right, break left, go well, go poorly for us. But we do know, and I threw up this chart to emphasize, like, a lot of our local communities are signing on to get involved with this. I get, like, preemptively exhausted kind of looking at this map. I'm like, this is so much work that we have to do, so much advocacy, so much education. And I want to emphasize that we do know what to do, right? We do have evidence-based strategies. We do have our public health authorities advocating for very, very clear evidence-based approaches. You will not find certain evidence-based approaches that are extremely important, like supervised consumption, safe supply, decriminalization, legalization in this document, because the CDC is bound by federal law. They cannot advocate for things that are in violation of federal law. Congress has to make that change, but we know, essentially we know what to do, right? Like this, we're not out there hunting in the woods for solutions to this problem. We have them in front of us. We just don't have the political will to put them into action in a meaningful way, because our stories are morally ambiguous, because the way we talk about substance use is based on emotion passion and value, and because we pack all of our weird social and emotional baggage into this idea of addiction in a way that is just astonishing and unhelpful. And I bring up this document specifically, not only because, well, I mean, full disclosure, I wrote it, so I hope it's helpful, but also because it was meant to be the sort of community guide to like overdose prevention for dummies. But it was mentioned actually in the talk at OPDAC that I mentioned. And so the memorandum of agreement coming out of the AG's office, I think already has a lot of really good sort of guardrails that are up. They have a series of, like, this is under option A in the memorandum of agreement, if you want to skim through it. They have a few approved strategies, things that people just can spend their opioid settlement money on if they want. They call them all evidence-based approaches. They are not all evidence-based approaches, sometimes because like recovery housing, we haven't really done an experiment with that where we give some people housing and other people not housing. There's not a strong evidence base, but we know it works. Others, like post-overdose outreach programs, we know that whether it helps or hurts people depends on how it's implemented. So there's some wiggle room in here, but they advocate reasonable stuff like evidence-based treatment, recovery services, naloxone distribution, SSPs, treatment for incarcerated persons. And they even threw up that same document. This is a presentation from the North Carolina Institute of Medicine, while not only advocating for evidence-based approaches, but advocating for the direct involvement of people who have lived experience of substance use, lived experience of being criminalized and oppressed under our own laws in North Carolina in the process of designing, implementing, adapting, and evaluating all of these programs. And that's amazing. I'm so glad that that conversation is happening at the state level, but I kid you not, like over on the right, I didn't include the full chat because I'm just not that kind of person. But there is a conversation happening in the chat while this presentation is going on of folks trying to figure out how to spin their opioid spending plans so that they can use it on early childhood education. Right. So like, I used to be a Head Start teacher. I really appreciate early childhood education. It's extremely important and it's underfunded and it needs our money. But the conversation that was happening, like the second folks started talking about involving people who use drugs in the process, it was like, how can we still like playgrounds, new swings, better teachers, new book? And it's like, it was astonishing to me. So this conversation has barely started and our most valuable and most effective partners are already being shut out of it because we're being real dumb about it. And that's my professional assessment. We're being real dumb about it if we are not making every single opportunity that we can to step back out of that space and let the people who need to be in it step into it. So that's the end of my rant. I will stop there. If you have any questions or if you want me to send you any of the resources that I talked about or shared, I'm happy to do so. And I will turn it back over to Deshay.
Okay, there we go. Oh, wow. Oh. That's my comment. It was a lot to digest. I feel like I've had a whole like serving of harm reduction policies. Like I had an appetizer, a main course, a second main course, a third main course, and now we're about to get dessert with these questions. So before I ask my questions, did anyone else have any questions? Feel free to unmute yourself or feel free to just add them in the chat. We've got about 4 more minutes until our session is over. Okay, so one of my questions is I know we've talked about how it's important to have people with lived experience, people who do use drugs actively or have a history of it, to be able to engage in some of our advocacy, engaging in talking about where we are spending some of that, the opioid settlement money. What are some ways that you think we might be able to do that? I feel like Louise might have a couple ideas, but what are some things that you all think, or like some areas where we can just sort of plug them in? Hey, here's a good spot to start.
Could you repeat the question one more time? Places we can start around the opioid settlement money, is that what you said?
The question is, where are some areas where we can really plug in people with lived experience to do some of the advocacy, either through storytelling or through engaging with the opioid settlement and, talking about, well, this money would be great if we could use it for this, because I know for a fact that this is what I need.
I just really want to say this. This is my big sort of piece right now. We need to really be mindful what meaningful engagement and inclusion and all of that really means. And what that means is that we need to do some serious pre-work that we haven't done yet with people that use drugs. No one has made the kind of investment in the drug using community that needs to be made for us to really do the kind of work that needs to be done. We have something very special in the national union where lots of drug users have done I'm sorry. I'm so sorry. I don't know how to turn all these devices off. But we have something really special in the national union where lots of drug users have done lots of work unpacking the drug war and how it affects their lives and all of this stuff. But you can't have meaningful inclusion, and you can't engage meaningfully and do these things, meet people where they're at and all this stuff. Those are all just buzzwords if we don't make the proper investments in the drug using community. So when I hear us talk about how are we going to include drug users in the settlement, wow, I hope that somebody will help groups like North Carolina Survivors Union, North Carolina Harm Reduction Coalition, some of the groups that are really engaging with drug users, get some grant funding to do some leadership development and to do some training so that we have people that use drugs ready to educate and advocate with folks. Because you can't just pick drug, like this idea of expertise, and we're about to put out some guidance around expertise. You're not just an expert because you're a drug user. You may be an expert at this, or you may have expertise over your lived experience, right? But you're not an expert. And what you'll do is you'll just parrot the stuff that you've been told. Oh, it's a good thing I went to prison. Oh, it's a good thing they separated me from my children. All of these things, because it's all you've ever heard. And it's the way the drug war has impacted your life. So I don't mean to go on and on and on, but we gotta insist that the grant language be defined. So I have encouraged Kathy and some of the folks working on this to not allow people to use these buzzwords in conversation. And we're going to actually create some bingo card guidance so that when people use them, we can put it out and say, well, what does that really mean? What are you talking about? How are you going to do that? What does that look like? Like, because I believe in high impact teams, like team building, high impact teams. I think that's the way it goes, but it's more than just a conversation. It's a relationship. The reason that Jen can talk about some things and do these things is because she has a relationship with North Carolina Survivors Union. The reason we can do some things, and we know some things about this and that is because we have a relationship with Jen. And I can call Jen up and I can say, Jen, I got all these questions. I don't understand what the fuck is going on. Please help me. Or I can call Anna. I can do these things because there's relationships being developed. I am not enough though. I'm one person. I'm tired. I'm a white middle-class woman with privilege, with lots of lost privilege. But I'm one person. I'm one person, and I don't at all count for all of the people that need to be at the table. So that's my fight. That's what I'm going with. Like we've got to do better. And this is a good time to say, hey, let's make these formal investments in this community. And then this shit works for years to come beyond the opioid settlement money, beyond everything else. We have a real investment in a community that can help inform programs and policies and all of this stuff that can help decrease death, improve life, all that good stuff.
Thank you. Anna.
I mean, one thought I have is to really encourage to the extent counties are forming groups within the county to figure out how to spend the money, to really encourage them to have a representation from a syringe service program that services that county. I think that's just kind of an easy soundbite to give to the counties. Make sure you have syringe service representation, because I think by definition, if you have that, you've got someone with a finger on the pulse of people who are using drugs. And then hopefully that syringe service program, if the representative of that of the program is not a person who's using drugs or with lived experience, sometimes it's like a parent of a child who's overdosed, they could bring in maybe one of their participants to talk. So that would be one way to do it that I could think of.
Jennifer, did you have any last thoughts before we wrapped up? Because we got like probably 2 minutes before the room force closes on us.
No, I'm super eager to pick Anna's brain about what cops are thinking about paraphernalia laws, but that's a personal interest. No, I'm totally happy to leave it on that note. I want to thank everyone for their attention, and let's go get some shit done.
Awesome. Thank you all so much. Thank you, Anna. Thank you, Louise. Thank you, Jennifer. Y'all were amazing. Again, this could be like a whole little separate workshop. So if y'all get an email from me in a couple of weeks saying, are you available? Know what it's going to be about.
For you, anytime.
I'll say yes.
Awesome. Thank you all so much again for the education and being willing to give us some tips and some feedback. And we'll be seeing you all pretty soon. Our next session's at 12:30, and we'll be talking about how to engage Black harm reductionists in the predominantly white space. So
Thank
hope to see you there.
Thank you for having me.
Thank you all.
Guys, bye.